Excited to invite Dr. Kristen Wolf to talk about pain management, particularly if you are someone who lives with sickle cell disease or the caregiver of someone who lives with sickle cell disease. We are very well versed with pain, as confusing as it can be.
Talk about the Australian context, which has been covered a few times today, so we won't go into that in too much detail. Talk about acute painful sickle cell episodes, and then just compare and contrast that a little bit to chronic pain in sickle cell, because they are quite different and the way that we treat them is different. With a bit of a conversation throughout about how we develop future research in this area and develop our own guidelines. So as we've talked about a lot today, sickle cell disease is rare in Australia, but is common worldwide. I've seen some different data about prevalence in Australia, with some estimates of about 1,000 people with sickle cell disease in Australia, or possibly more like 400 registered with our hemoglobinopathy register. We expect this prevalence to increase with migration. And a high proportion of those with sickle cell disease in Australia are young people, so children and teenagers. We're managing this within a resource-rich country, but I am conscious, particularly through the discussions today, that our context is different to places like America or the UK, where a lot of our data comes from and a lot of our guidelines come from. And so the way that we manage things is different. There's a clear research gap. So we have a clear lack of Australian-specific data related to pain and sickle cell disease in Australia, full stop. We don't know a lot about the epidemiology, and when I've been looking for data in the last couple of weeks, I couldn't find any published reports of epidemiology, patient and family experience. And I suppose from my lens as a pain specialist, I'm thinking about the broader opioid discussions that we have. So when we look at pain data that comes out of the US, there's of course a strong emphasis on the opioid epidemic, and that's a really important discussion to have worldwide as well as in our Australian context. It's important here as well, but I do think that our context is different, and the way that we use opioids is different. So we're looking at developing Australian guidelines for pain management and sickle cell disease, which I'm excited to say we are in the process of doing. It's a process, it's coming along. The majority of the evidence that we're reviewing is it's all overseas based. And so it's almost a process of analysing that data, looking at the recommendations, and then thinking about how they apply in our context, which is sometimes easy and sometimes not. So just taking it back a bit, what is pain? I think everyone would have a different definition, but if we're looking for official definitions, pain is a sensory and emotional experience due to real or perceived danger to the body. And so there's a few bits in that. There's a sensory part, so part of your body that feels uncomfortable, but there's always an emotional experience of pain as well. So pain is unpleasant, we know that. And that affects the way that we experience pain. And pain is all about a balance of safety messages and danger messages in our body. So pain is designed to be protective. If we think about it really simply, it's designed to tell us that there's a threat to our body or to ourselves. So thinking about acute pain, if we cut our finger, our body has this pain response that's designed to tell us that there's danger and we need to do something about it. And I'll just leave that so that we can come back to it a little bit in chronic pain. So just what is acute pain versus chronic pain? From a definitions perspective, it's purely about time frame. So it's nothing to do with severity, and that's important. Acute pain is short term, I suppose. So it's sudden in onset, it's time limited, and the idea is that it motivates us to do something to avoid danger. Chronic pain, a simple definition of chronic pain is pain that persists for more than 3 months. Yeah. And in the context of sickle cell disease, we know that worldwide about 30 or 40% of adolescents or adults develop chronic pain. So as one thing I'm interested in is whether that changes if we manage acute pain better. The mechanisms of acute and chronic pain are different. So in sickle cell disease, we know that the acute painful episodes are related to recurrent vaso-occlusion from the sickle red blood cells, and that leads to an ischemic lymphofusion injury. Chronic pain is quite different. It's more about how our nervous system or our pain system gets oversensitized or gets very good at giving us danger signals. It's almost like that protective pain system gets overprotected. And so, just taking it out of a sickle cell context for a minute, one way that I tend to explain this to my paediatric patients is using the analogy of a smoke alarm. So a smoke alarm is really helpful. It's there to keep us safe. It's there to tell us if there's smoke and there's a fire, and so it starts alarm. Sometimes the battery's broken though, so there's no smoke, and we've got our overprotective smoke alarm that's giving us danger messages even when there's no danger. Or maybe it's more like a guard dog. So thinking about a German Shepherd, for example, it can be really helpful if we've got a guard dog to tell us if there's an intruder at the front door. But sometimes our dogs can be overprotective, and so they're barking when the postman's there, or someone's come to drop something off, or your mum's come round. Or maybe you've got a really overprotective dog who's just barking in the middle of the night for no good reason. And it's the same with the pain system. It can get overprotective and give us danger messages when it's not as helpful. So why is pain important in sickle cell disease? Because it's really common. So acute painful sickle cell episodes are the most common complication of sickle cell disease. Account for the majority of healthcare utilisation for this condition. And as I said before, many people with sickle cell disease go on to develop a chronic pain condition. And pain really impacts people's lives. So it's unpleasant. It impacts everyone around it. So it's got a clear impact on the person experiencing pain, but also thinking again about children, parents. It also impacts function. So if a young person's experiencing a lot of pain, generally can't go to school as much, can't do the things that are fun, can't play sport. Parents then will generally have difficulty getting to work. It just goes on and on. So it's important that we treat this better because it affects everyone, and there's clear systems and healthcare resource arguments that we can make as well for treating pain better. There's a little bit more on these acute episodes. As I said, they're the most common reason that an individual with sickle cell will seek medical attention. Intensity ranges from mild to very, very severe. Protection and overprotection. Generally, the durations from hours to days. And we know that whilst these are the most common reasons that someone might present to hospital, the majority of episodes are actually managed at home. They can occur from infancy, but generally increase in frequency with age. They begin suddenly and most commonly occur in the chest, back, arms and legs and abdomen. And we know that in young children, dactylitis, so affecting fingers and toes, is common. It's also common for pain to be present in multiple locations. Lots of different triggers, things like cold or windy conditions, having an illness at the same time, dehydration comes up over and over again, stress, things like alcohol and also menstrual cycle. Yeah. For the clinicians. I think we all know this, but there's no magic test that tells us when someone's experiencing an acute painful sickle cell episode. And the gold standard evaluation is what patients and families tell us. So reports of pain, pain severity, and comparing it with previous episodes. So many people with sickle cell disease who've experienced these episodes can tell us when they're experiencing a sickle cell episode. And we know that it's the patient and family who are the experts. We need to use age-appropriate pain assessment tools for infants and children who are less able to tell us in words what's happening. And we do have clinical assessment tools that we can use. It's really important that we give pain relief whilst making the evaluation, so these occur concurrently. I suppose that should be the same in any condition, but we don't wait for test results to come back before treating pain. And so we should never be delaying analgesia whilst we complete that evaluation. It's important in the guideline development because it plays into recommendations we make around triaging and emergency department procedures. Then we need to think about whether pain is related to an acute episode, whether it's occurring concurrently with another vaso-occlusive crisis, and just remember other complications of sickle cell disease. So we also need to remember that pain isn't necessarily related to sickle cell disease, so we need to not forget about things like appendicitis and other causes of acute pain. So having a really broad approach. The previous speaker was actually talking about this, but I think it's important to talk about stigma as well and recognise that the attitudes of healthcare practitioners really influence everything, but certainly influence how we assess pain, how we treat pain, and our patients' and families' experience of pain as well. And negative healthcare attitudes are incredibly damaging. So again, this comes from overseas experience. It may be the same in Australia, but when we have clinicians who don't believe a patient's report of pain or are assuming things like drug-seeking behaviours, it's incredibly damaging and in a number of ways. There's a bit of a shift away from the use of pain crisis towards painful episodes. Words matter and language matters. And I suppose that's for a couple of reasons. Crisis might have connotations that suggest that individuals don't have the ability to manage pain well, and we know that that's not true. And again, most pain is managed at home. Also, from a chronic pain perspective, there's a concept of pain catastrophizing, where we know that how we think about pain affects pain itself. So if we're encouraging or suggesting a crisis or tissue damage, we might be making suggestions that promote chronic pain. So just a little bit about how we can manage things well at home. So simple stuff like if we know what triggers are common, where possible avoiding it, recognising that it's impossible to avoid triggers all the time. Regular use of disease-modifying therapies such as hydroxyurea. And for those times where regular pain medicine is useful, taking it regularly. Hydration, particularly in warm weather. And then general health. So this is true for sickle cell disease, but it's true for all chronic pain, that when we can work well on things like sleep, nutrition and activity, movement, it really helps pain. It's helpful to have plans in place for what to do in the event of an acute painful episode. And I can't remember if I get to slide on it or not, but I really advocate for developing individual management plans for everyone with sickle cell pain. So having a plan that we come up with together, using non-pharmacologic therapies, so things like heat, generally not cold, so not cold packs, because that can worsen things. And then having a stepwise management plan for when we have painful episodes, so simple analgesias, Panadol, maybe non-steroidals like Nurofen, but we'll talk about them in a second. And then generally it's helpful to have a plan for how we can have access to the strong opioid in the event of these episodes. But then really importantly, how and when to seek medical attention. And again, that was highlighted in a previous presentation that where possible, generally the emergency department is not a pleasant place to present when we have pain. So where possible, having systems so that we can contact clinicians who know us and know how to manage these episodes well is helpful. Sometimes you've got to go to ED, if it's 10 o'clock on a Sunday night, generally that's the only place, unfortunately, but where possible, it's good to have other options too. So again, for clinicians in the room, when we're treating acute pain, it's like always in accordance with the WHO letter for pain relief. So starting with the simple analgesia and Panadol. There's some conflicting opinions about the use of NSAIDs in sickle cell disease, quite conflicting. And so some people are not at all concerned about using NSAIDs, particularly short term. And we talked about the pro-inflammatory state and so NSAIDs can be really helpful in reducing that inflammatory state. Equally, if we've got concerns about side effects, mainly renal side effects. And so this might be a difference between paediatric and adult guidelines. So generally in kids, we're less concerned about renal side effects, particularly if we're using NSAIDs for a short term. And yeah, very conflicting opinions in adult data. So some people really don't like using NSAIDs at all. Other people more relaxed about it. So I'm not really sure what the Australian consensus is. And I'm interested in people's thoughts. And opioid analgesia absolutely is indicated in severe acute episodes in hospitals. So absolutely appropriate to offer a strong opioid, usually oral in the first instance, but then we've got escalating pathways for other avenues. So intravenous, sometimes things like intravenously are useful as well. And the choice and dose of opioid analgesia is generally just in line with local protocols. So this is something that we're discussing as part of that working group. But rather than making broad recommendations for all hospitals, using the hospital's usual approach is generally the right thing to do. But thinking early about things like PCAs or nurse controlled analgesia and consulting early with NPS. Talked a lot about hydroxyurea today, so I won't labour this point, but it's definitely indicated when people are having multiple episodes of acute painful sickle cell episodes, particularly if we've had 3 or more within a year. Red cell transfusions is a little bit more contentious. So they're rarely indicated with acute episodes, but may have a role in those individuals who are having recurrent painful episodes or with refractory pain setting. I have to say our anecdotal data has been quite positive in years recently in South Australia. But again, this is an area that I'll be really interested in people's thoughts. So yeah, talked about that a bit before. Really helpful to have individualised management plans which are available to patients, families, emergency departments, clinicians, GPs, everyone, and making sure that they're writing in the right language. So yeah, chronic pain definitions, talked about this before. So unusual definition for chronic pain is pain which persists for 3 or 6 months beyond the time of normal tissue healing. And that's easy for something like a broken arm, where we know what the pathway for normal tissue healing is. And then when pain's persisting beyond that, we've got chronic pain. That doesn't really work in sickle cell disease because we're always going to have those intercurrent, well, hopefully not always, but we are sometimes going to have those intercurrent acute painful episodes. So a proposed definition is having pain on most days over 6 months, either in one area or multiple areas. And in the sickle cell condition, this might be due to reversible conditions, so bone and joint pathology, and again, we won't go into this too much now because we've got an upcoming talk. But also that pathway central sensitization. I'll talk about it again in a sec. Hyperalgesia is where we experience more pain than we might expect from a from the stimulus, or when the pain pathways get ramped up. And opioid analgesia, unfortunately, can actually contribute to this. So sometimes using opioids over a long period of time increases those pain messages and can have a paradoxical and unfortunate effect. And we know that in chronic pain and tissue damage don't correlate. So you can have no tissue damage and terrible pain. You can have a lot of tissue damage and no pain at all. And again, it comes back to that danger safety messaging, which is what this is about. So this is just a basic explanation of pain pathways, which we don't need to get too hung up on, but essentially we can have pain's all about your nervous system, and pain is always interpreted by your brain. So that doesn't mean that pain's in the air, but that your brain has an important role in modulating pain signals. So we learned this in med school, that essentially you've got a nerve that might take a signal from a tissue that's may or may not have tissue damage, comes to our spinal cord, sends another pathway up to our brain. And we do not have a pain area in the brain. It's a complex web of inputs from all different areas. So you've got bits of your brain that are useful in memories or feelings, emotions, all kinds of things that play into that pain experience. And I guess that's important because it's also how we treat chronic pain. So whilst our pain system can get overprotective, and it's almost like that rolling dial has been ramped up, we all have neuroplasticity. So our brains can change the way that those pain messages are interpreted. And even in chronic pain, so pain that's gone on for longer than we want it to, we can absolutely change those messages and turn those rolling dials down. Just brings me to the biopsychosocial approach to chronic pain. And this is just to say that pain is not just about what's going on in your body. And so it's not just about those nerves. When we think about pain, we know that it affects all different types of your life, all different parts of one's life. So there's the biology, so things that we've been talking about a lot today, so our genetics, injury and illness, the haematological system. And that's part of your pain system, but then also the psychological aspects, so thoughts and memories, trauma, emotion, how we behave, all of that is part of your pain experience as well. And social, so that's your family and friends, culture and ethnicity, school, neighbourhood if you're a child, and activities and hobbies. And I guess just the reason that I'm bringing this up is because unlike acute pain, which sometimes has an easy way of treating with medication, we know that that's not the case in chronic pain. Unfortunately, often medications that work well in acute pain don't work well in chronic pain, which is a shame. And so when we're managing chronic pain, it's always focusing on all of these areas, because the same as pain has components from all of these areas, so does comfort. So this is the same model, but more specific to sickle cell disease. So biological factors might include hematological things, inflammation, that nervous system dial-up. Having pain for a long time often affects your mood. It's unpleasant, and so it's common that having pain for a long time is a really stressful experience. And so that's important in how we help with chronic pain as well. My thoughts on opioid analgesia and chronic pain in this area, because it's a really fine balance. There are lots of reasons that we get nervous about using opioids in general, but certainly in chronic pain, there's a lot of risks, there's a lot of side effects. We all know this. And they're side effects that are both acute and long-term. But I guess it's not just about the risk, it's also because sometimes there's also not a lot of benefit in opioids long-term, and that's the bigger thing. So if we've got risk without benefit, that's not helpful. I'm just going to go forward and then back a little bit, because I think what we're trying to do is balance different paradigms, because our classic acute pain paradigm has a lot of opioids in it, and that's okay. Our classic chronic pain paradigm is very anti-opioid. So generally we're trying to reduce opioids, stop them where we can, because we know that they're not helpful. But again, I don't think that's right in sickle cell disease. I think the right approach lies somewhere in the middle. Sometimes it absolutely is a role, but it's just about carefully thinking about the right way. And there's no good answer in the literature when it's all over the place. So how do we accurately assess and balance the risks and benefits of opioids? And how do we get that balance right between providing adequate and necessary opioid analgesia, but not escalate unnecessarily? And this is definitely an area that I think we need more research in. I just mentioned methadone briefly because people ask me about it a lot. And when I talk about methadone here, it's in the context of using it as a pain management medication. Methadone is a opioid agent that's used in different ways in Australia. So it's sometimes used as an opioid replacement program, but that's not what I'm talking about. I'm talking about how we use it in chronic pain management, particularly sickle cell disease, because one of the reasons that it is often helpful is because of the way that it has, in addition to that opioid agonism, NMDA antagonism and monoamine uptake inhibition. So it works on a number of different pathways. It's got a lot more neuropathic action than many of our more classic opioids. And so this is why it's quite commonly used in sickle cell chronic pain. It's a really tricky drug to use though. So it's got very complex pharmacology. It's got a long half-life. It's got a lot of side effects. It's a really useful drug, but it's always hard to put in. Don't use it by yourself. Maybe switch your page. Very happy to help. I think that's all I'd thought to talk about, but is there anything that anyone else would like to discuss or ask questions about?
Is Louise English. Louise is joining us from South Australia, and she'll be talking to us about the Sickle Cell Disease School Program in that state. Welcome, Louise.
Thank you. So thank you very much. My name's Louise English. I'm the nurse consultant for haematology and cellular therapies at the Women's and Children's Hospital in Adelaide. Firstly, I should acknowledge that the land that I'm on today is the traditional lands of the Kaurna people, and that I respect their spiritual relationship with their country. And I also acknowledge the Kaurna people as the custodians of the Kaurna land, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. And I also acknowledge the traditional custodians of the land upon which we're all attending today. So my position is a relatively new role. We had some funding promised pre-election here in the state elections in 2022 for a number of new nurse consultants within haematology and oncology at the Women's and Children's Hospital. So I commenced in May this year, and we are in the Michael Rice Centre for Haematology Oncology, which is in this red, white and grey building here in North Adelaide. And currently we have got 21 children with sickle cell disease being treated in our service. I'm just very briefly going to tell you what we've been up to so far. And for me, it's really been around increasing the profile within our unit around all children with haematology disorders, or non-malignant haematology disorders, I should say. I think in a combined haematology oncology service, it can be really tricky for those who don't have cancer, because there's a lot of emphasis placed upon cancer care and cancer therapy. So I've been really trying to increase the profile, including around World Sickle Cell Day this year, where we had a bit of an education push with our nursing teams. We've also implemented a red cell exchange program since June. So all of our children who were on regular transfusions have now transitioned over to a red cell exchange program. So we're really happy with that. Next up will be the implementation of a comprehensive care clinic, which we're aiming to start in February next year. And what I'm going to be talking about today is the school program, which has already been underway since 2021. So this is not my work. I'm not going to take any credit for the work that's been put into this. This has certainly all been before my time in the role. So I'm going to try and do the team justice that have been working on this by presenting their work today. So the program is overseen by the Haematology Oncology School team, and this team is led by the school liaison nurse. So the school liaison nurse is a registered nurse from within haematology and oncology who puts in an expression of interest to do this position in addition to their clinical role as well. And this position rotates every 12 months. So we have had quite a number of nurses go through this role up until now. And this team consists of, it's led by the school liaison nurse, but we also include all of our haematology oncology nurse consultants, the hospital, school, South Australia educators, we have psychologists, as well as other allied health professionals that sit on this team, particularly social workers as well, who can work with us on supporting the interaction between school and children with haematology conditions. So the school liaison nurse position commenced in 2016. It initially was for children with a cancer diagnosis, and it expanded in 2020 to include all children and young people treated in the service with a haematology disorder as well. It is a charitably funded position, so the money that pays for this comes from the Women's and Children's Hospital Foundation, and it is provided by Amazon, I've been informed in the last few weeks. And what it does is it pays for a registered nurse 20 days per year. So this works out to just 1 day a fortnight for during the school term. And that person provides a school liaison service to all children with haematology and disorders or a cancer diagnosis. And to put that into context, we have about 60 children per year diagnosed in South Australia with cancer or with a haematology diagnosis. Not all of those children are obviously at school. So the service covers those from kindergarten all the way through to year 12. So why do we need a school visiting program for children with sickle cell disease? Well, we know from the literature, again, not Australian literature, but up to 60% of adolescents report that sickle cell disease interferes with their school performance. And this is more so in female students than in male. And we know that absences from school due to pain crises, pain episodes, I need to change my terminology following that last talk, medical appointments, treatment visits, and other complications of sickle cell mean that children are having absences from school. And what can happen due to these absences is if there's instruction that's occurring during those lessons that needs to be built upon in subsequent lessons, it can be really hard for students to catch up when they've missed out on that foundation learning. We also know that there can be decreased school performance for children with sickle cell disease due to chronic pain that we've just been hearing about, fatigue as a result of anemia, which can affect concentration, as well as cognitive impairment, which is a risk for children who have experienced a stroke or who have had silent strokes, which are those that aren't obvious as a clinically obvious to anyone around the child, but are just picked up on MRI that there has been some changes in the brain. And these changes can impair reading, language, visual motor processing, memory, attention, and other executive functions. I think we also need to consider that there are some compounding factors as well, particularly for us in South Australia. I can't reflect on other states, but a lot of our families are new arrivals to Australia and do have English as a second language. We then ask them to come into a health system and an education system which is entirely different to where they have migrated from and navigate these complex systems. We then need to consider the background of those that have recently arrived in Australia, in that there may be experience of trauma, separation from their culture, and the usual mental health and well-being effects of migrating to a completely different country and potentially being separated from support systems. So the school can play a vital role in helping to, I guess, prevent crises in children, and also, I guess, meet all of the complex needs for this patient group. And again, there's not any Australian research to support this, but there is some evidence that the nursing support that we can provide will actually help that integration between school and health system as well. So what does the school visiting program for us involve? First and foremost, consent. So we will not disclose information or make any contact with a school without the express written consent of the family or the young person. And I think that's really important to recognise straight up. Certainly in some cases, families prefer to make that contact with the school themselves, and we can certainly provide care plans and written information to the school via the family, which they can then disseminate at their own discretion. Once if they do provide consent for us to share information, then we put in a referral to the hospital school in South Australia, and we start developing a care plan. So this care plan is developed between the school liaison nurse and the treating doctors for each child or young person. We can then send, we then get in touch with the school, and we can provide them with written information and the care plan, or, as I said, provide that to the family to pass on to the school. We then do a school visit, which is done either by the nurse or the nurse and one of the teachers from the hospital school. And then we can provide follow-up and evaluation of how that visit has actually gone. So these are some of the care plans that we use from the Department of Education in South Australia. Essentially, any child with a chronic illness that has an impact to their first aid requirements or to how it may actually impact on their schooling needs to have these put into the submitted to the school. So this would be for children with anaphylaxis, asthma, but we also do this for sickle cell disease. So we have a first aid plan. So this just outlines any different first aid response that a child might need. So for example, with sickle cell disease, not applying ice packs if there's an injury. And then we have a non-specific healthcare plan, which really talks about how chronic disease may impact on their education. We have then developed this resource, which Dr. Monika has kindly brought some along today to hand out so that you can have a bit of a closer look. And this is based upon guidelines from the Royal Children's Hospital in Melbourne, but was written for our patients by Dr. Monika Powell and Kelly Ailes, who was our school liaison nurse at the time, in conjunction with Matthew McCurry, who is the principal of our hospital schools in South Australia. Importantly, it was reviewed by consumers. We need to make sure that it's actually meeting the needs of consumers as well as haematologists and nurses. This resource was approved in 2021 and has been in use ever since. And I don't think I can overstate how important it is to have really good reference material for the schools, given that we don't have the funding to have a nurse present at all times for the staff to be able to refer to. So, and not all people or not all employees of the school are going to be present at a school visit. And obviously teachers change year on year. So it's really important that they have a really good reference to be able to refer to. So what is in this little manual is there's quite a few different topics that are covered. Initially, what are the key actions during a crisis? So situations in which they need to be calling an ambulance. So severe abdominal and chest pain, any signs of a stroke, those sorts of things. Situations in which they need to be contacting the family or carer in an urgent manner, such as fever or more mild to moderate pain. There's then a section on how school teachers can actually help avoid a crisis. So making sure children and young people remain hydrated, allowing frequent bathroom breaks, and monitoring the temperature and environmental conditions so that children are not becoming too hot or too cold. There's a section on educational impacts of sickle cell disease, the effect on learning, emotional well-being. There's a section on bullying, and as well as advice from teachers to other teachers about how to support children with sickle cell disease, and some medical information as well around what sickle cell disease is and how what complications can be anticipated. So the school visit itself it varies a little between whether it's in person or via Teams or Zoom. Certainly during COVID times, it was almost universally via Zoom. It's typically around a 60-minute visit, sometimes closer to 30, but often 60 minutes, because I've been told there is a lot of discussion and a lot of questions that get asked by educators to the team. And the attendees vary depending on the needs of the child and the requests of the school. So at times, we find that the entire teaching team may come along to that visit. Other times it may just be one-on-one with the year level coordinator or the school nurse or the first aid team, or it really does vary quite considerably. So it could be 1 person, it could be 30 or more. And the information that we provide during this visit is a background on the disease, treatment that the children and young people may be receiving, complications that we have seen, and then any specific information about the complications that specific child has experienced and how that may need to be managed in a school environment. What the role of the hospital school in South Australia is, so they can provide teaching if the child is an inpatient for any reason in hospital, or if they're coming in for outpatient treatment visits, they can actually receive education in a continuous manner, and they can liaise with the child's home school to be able to provide that. And also any supports that are available. So if there are deficits in learning, or we're finding that children are having a tough time in particular subjects, any tutoring schemes that may be available to them. So far we've done 8 school visits for children with sickle cell disease. Information packs have been provided to an additional 6, and we do have 5 that are currently not at school or kindergarten. So we do have a number of visits still to do. We're certainly increasing the number of children with non-malignant haematology disorders who are receiving this service. So you can see here in 2021-22 financial year that it was actually the 2nd largest group that got school visits in South Australia. So that's really positive for us. And the feedback typically is overwhelmingly positive. The schools really appreciate this service. I think the families feel as though their children are being supported and are receiving safe care when they're at school as well. So I just need to acknowledge the school nurses who have put in an incredible amount of work into this program. So Renee, who is our current school liaison, and Kelly and Rob, as well as all of those that came before them. The hospital school SA team are absolutely incredible in the support that they provide to the children and young people in our service. Dr. Monika Powell, who's with you there today, and the rest of the haematology team, and importantly, our patients and their families who entrust us to support them with their schooling as well. And obviously the Women's and Children's Hospital Foundation, who pay for this service. So that was all I was going to present today. And I'm happy to take any questions, and I hope that my trusty assistant, Monika, has been able to distribute some of those handouts for you.
Do we have questions in the room? Okay. Do we have questions? No, she's asked whether there are any questions for her in the room. Agnes, do you want to you do my job?
That was a fantastic presentation. Thank you, Louise, and here from Children's in Melbourne. I just wondered about focus on teenagers, because I suspect the information is different for junior school and high school. You may not have encountered this yet, depending on the age of your patients, but I just wondered if you thought about that next phase when all the Olympics get to high school, because I think it's a different dynamic.
It is. I think the information that is provided is fairly consistent between the different visits. I think in high school, the children are very much taking on a lot of their own healthcare and seeking out that support when needed. So I don't think that the teachers play as much of a role in a lot of that health maintenance stuff. But the information that we provide during the visit and the support that we provide is the same regardless of whether they're in kindergarten or year 10. I guess it's just very much tailored to the individual, and those healthcare plans are very much tailored to the individual as well. So it really depends on their own complications and how they're tolerating their treatment as well. Certainly, we've had some issues with medication compliance in some of our adolescent patients, and the hospital school has also been able to liaise with the home schools as well to be able to provide some supervision in those years for medication administration as well. So I think it's very much about that link and just forming those relationships with the school so that there's that ongoing communication.
Okay. Any more questions in the room? Anyone? I don't know. I think there was a question. Anyone? Okay. Okay, great.
Thank you so much for that, Julie. It's a very, very good program. Just maybe a question or comment towards Dr. Greenway and other doctors here in Melbourne. Would you think that's something that can be implemented in Melbourne and other states as well?
I think most of the states do something similar, but I think many states do something similar, but probably not as well coordinated. And particularly in many centres, there's a strong focus on patients who are coming in with regular transfusion and regular blood change, because we know those patients every single month. Once the hospital administrator will have a school liaison with the teachers, very similar to Adelaide. I think the other thing that's really important that you guys have done very well in Adelaide is to make sure that patients coming to clinic know over 2 or 3 times a year or that program. Probably underestimate cumulatively how much education is adapted to that over time.
Okay. Are there any more comments? Okay, Louise, can you hear me?
Yes, I can.
Okay, great. Okay, I thought that was a really awesome presentation. As they say, it takes a village to raise a child, and particularly for a child that is affected with sickle cell disease, you know, the family and the child definitely need that village. And I absolutely love the concept of extending that support through the school, where it's not just, yes, show up and learn how to count and read and all of that. When a child is affected by this particular condition, it can be a bit more stressful. So it's very good to see this type of model. And we hope that every child in Australia that is affected by sickle cell disease does get to benefit from such a program. So